one of Britain's busiest major trauma hospitals.
Can you open your eyes and look at me? Just need to see your eyes.
Filmed in January and February this year, during one of the worst winters on record.
You know, patients are waiting on the corridor that are really sick, but we can't do much for them because there is no space.
Have you got any beds? I know that it's tight, everybody's over.
This series documents a moment of crisis in the NHS.
The queuing to get in, and he's queuing to get out.
Can't do that one. We've got no bed for him and no potential bed for him.
Prompting actions as unexpected as they were unprecedented.
We are being asked to cancel any non-essential activity. So not cancer, not clinically urgent, but pretty much anything else.
We're being paid to work, but just trying to find something constructive to do.
I'm afraid it's bad news. We are going to have to cancel tomorrow. I'm really sorry.
We reveal the life and death decisions the staff must make.
The situation we've got is very severe. If we can buy her more time, then things should start to get better.
Against a backdrop of ever-increasing patient numbers.
There's never a day off for the NHS. Patients will still come and we'll still do absolutely everything we can for them.
Look at that, standing almost.
This is a place with some of the best specialists in the world.
The aim is going to be to try and grow your jaw and reconstruct the lower part of your face.
Where despite everything, lives are transformed.
It's been a long journey, but I think we're at the end now.
We were able to take, I think, probably all of the tumour out.
Look around. These are human beings. They're not numbers. They're not targets. These are your parents, your wives, your children. You know, treat them like that.
Nottingham University hospitals have run out of beds. To make space for the unprecedented number of patients coming in through A&E, the NHS has advised hospital trusts to cancel all non-urgent operations for the whole of January.
It's a national problem. We've never had a mandate like this to just cancel anything that's non-life-threatening.
As General Manager of Surgery, Jo Fort is in charge of 2,000 staff and a budget of £250 million.
It is going to lead to significant numbers of cancellations. Between about I think 400, 500 routine operations. And then, you know, you'd be talking thousands of outpatients also being cancelled as well.
We got the confirmation last night we are cancelling everything that's routine next week. Not cancer, not anything that's going to come to harm. Anything else has to go. This is about as bad as I've ever seen it. It's a mess.
Inevitably, when we're cancelling en masse to the level that we are doing at the moment, that has a big impact on our backlog numbers. You know, they're listed for surgery for a reason, so deferring isn't a palatable option. Some of these operations are, you know, life-changing, and you are effectively asking patients to put their lives on hold.
We have been told that we have to cancel all electives for next week.
Right, everything.
Yeah, so I think this, in reality, is probably going to continue to the end of January based on the NHS directive.
Thank you.
Thank you.
You just feel a bit of a weight on your shoulders, really, because it's not the situation that you want to be in. It's a huge responsibility, and it's a huge responsibility for my teams. But I've got the burden overall in terms of managing the fallout of what this means within the hospital.
The NHS has advised trusts to cancel all operations except for cancer or those deemed clinically urgent.
Right, can we start?
But it's up to individual hospitals to decide exactly which operations can and can't go ahead.
I think it's really important to say that we are still very, very challenged. What we need to be able to do with every decision we make is either comply to the rule that's been put in place or explain why we're doing it differently.
Rather than blanket cancel patients between now and the end of January and then find out in the last week in January that actually things are a lot better and we have the capacity to do them. We'll review it on a rolling 48-hour basis and we'll only cancel patients as we feel that we need to. So really we're just asking for the support of this group to that approach.
I strongly believe this is the right thing for our patients to do it in this way.
We've got to manage flow, we've got to manage the safety of our patients, but we've absolutely also got to manage the financial position as well as we can.
Any cancellations will have a financial impact on the trust.
There will be a financial legacy as a consequence, and the current estimates of that is about £500,000 a week will be the shortfall that's generated.
The NHS is an incredible organisation and we all want what's best for patients, but in extreme circumstances like we're working in at the moment, we have to find some way of prioritising. We've made the decision that what we'll do is we'll look at having a daily cancellations review. We don't want to cancel patients if we've got capacity to be able to bring them in. So it just gives us the ability to be able to be a little bit more fluid with our decision making.
Every routine operation remains at risk of being cancelled. Maxillofacial surgeon Dilip Srinivasan is meeting his general manager David Dolby to find out whether a complex and pioneering operation can go ahead.
If it's an inpatient and it's not cancer, it's a no, basically.
I have a patient called Val, who is coming from Wolverhampton. She has had surgery for cancer, which has left her without any lower part of the face.
Okay.
So we are going to try and reconstruct her. The question is, I'm planning to do her on the 17th.
Okay.
I'm going to see her on pre-op today. I will warn her that there is a small chance that she may be cancelled. I will warn her, but I know she's not cancer.
No, but do you think you can make a case for her being urgent?
She's urgent because she can't talk, she can't eat.
Okay.
So from that point of view, but she has lived like that for 2 years.
I know, but still, keep on. Give her a warning, but I'll do my damnedest to make sure she comes in.
Okay.
Yeah, that's Val before. Val's had 2 major surgeries which have failed, unfortunately, to reconstruct her face. And so hopefully this one will help to rectify that. Not
I hope
long.
it goes ahead.
Yeah.
Well, I've had 2 sick years already. My husband died 2013. Our dad died 2014, almost a year later. And then a year after that, I got diagnosed with cancer.
Val's mouth cancer completely destroyed her lower jaw. She's being offered a groundbreaking operation which could encourage a new jaw to grow in its place, using a technique called distraction osteogenesis.
Valerie's case is interesting because distraction osteogenesis is not new. It comes from leg lengthening originally. So little people want to make them taller, they would extend their legs. So that kind of surgery has been done for 100 years. We've done distraction before. We've done a half jaw, numerous occasions on both sides, but we've never done a full jaw. But that's meant we've had to come up with a very innovative solution to do that, a one-off.
So that's what is going to be around your jaw.
This is the device we're going to use in Valerie's surgery. These are the 3 pins that are going to go through on both sides to hold the bar, this device. So the pins push through the skin into the bone here. And then here, where this little line is where they're going to cut down through the bone on both sides. And then that pin will be in through this piece of bone. And then these 2 bars allow that pin to slide forward. As it comes forward, it will deposit bone on this edge here. The bone tries to grow. And as it's just about formed, you pull it 1 millimetre. You allow it to try and form itself again over the day. It just tries to form a callus. You pull it again. Over 45 days, that bone will be pulled forward along that bar and grow. And this is where distraction is amazing because it will bring soft tissue, it will bring nerves, it will bring everything. It will just stretch it all around.
It's a multi-step operation. This is going to be the first step. So, yeah, it is a long haul. But my aim is, if you do it in January by Easter time, we would have done everything. But You probably have heard in the news and everything about elective surgery being cancelled, etc. I mean, I've had a discussion with the manager even today, and our hope is that this won't be cancelled, okay? But it is not entirely in my hands.
I understand what the situation
I
is.
do have to warn you.
Despite the NHS advice to cancel non-urgent surgery, Dilip will continue to prepare for Val's operation.
Well, if it needs to be cancelled, then that's how it has to be. It's a privilege, not a right. Everything that they do for me, this is not something I take lightly or for granted.
How's life changed since you had your jaw removed?
Everything has. I can't eat anymore. I used to be quite outgoing. I was a post lady before, with my job, and I've had to pretty much stop everything.
So it's everybody helping Val to get a quality of life back. And hopefully, I mean, all she wants is to eat a boiled egg.
I miss a soft boiled egg sandwich I could just murder on.
So she's routine, so she's going?
Yeah.
Across the trust, staff continue to cancel operations.
She's going to have to go, isn't she?
God. I've got like plastic surgeons and everything booked.
But is it clinically urgent?
I'm really sorry that they are going to cancel your operation on Monday, and I really do apologise for that.
Okay, there's nothing you can do with it.
Yeah. I'm so sorry.
Oh, God, okay.
As the cancellations escalate, Joe meets with Chief Operating Officer Caroline Shaw.
Up to now, how many people do you think we've cancelled?
So we cancelled 104 for this week, and I think it was 48 for last week. And then I've written out to all the consultants today with a really clear plan of what we're doing. I've made it absolutely clear that despite decisions being made in other hospitals, we will make that decision on a daily basis for the rolling days going forward. So
it's good. And have we had much feedback from patients?
In the main, I think patients have been quite understanding. We have had one patient who has asked if she can sue us if she dies between now and getting her operation, which was obviously a bit distressing for the staff. She's non-life-threatening.
Looking forward, what's the plan to return into some kind of normality?
We will see an increase on some of our backlog.
What do you think the financial impact's been at the moment?
I will struggle massively to recover it, I think, within this financial year.
After 2 weeks of cancelled operations, the Trust is facing a loss of income of £800,000.
For every procedure that is undertaken, there's essentially a tariff assigned, and if we're just not seeing those patients in the month, then that is lost income.
The Orthopedic service is one of the hardest hit.
So that one can go to the city as well? Yeah.
Tony Westbrook is one of 18 elective orthopedic consultant surgeons.
What we're very proud of here is I think that, we've certainly got the best theatres and, the best teams in the area, but over the last few weeks, we've done very few elective operations. The NHS isn't all about finances, but without us doing the elective work, then we're not bringing the revenue into the hospital. Surgeons will turn up to work not knowing quite what's going to be on the list, if they've got a list. We'll then try to redeploy them across to the trauma side. The reality is we're well staffed on the trauma side, so they might not be needed there. You've got people, effectively just twiddling their thumbs, and, it's quite known what to do with them, really.
We finish in Theatre 5.
Okay.
So, any emergencies we can take on?
So at the moment, all the emergencies are allocated everywhere else, and there isn't a lot to do. So
are we closing down?
I think we should close down the theatre, shut down everything. We're going to shut down now for the rest of the day, so there's nothing else left to do. So if we just completely shut down, check drugs, clean sweep and everything, and then if there's any training or bits and pieces you've got to do for the rest of the day, or any paperwork, or anyone needs to come and speak to me, then see where we go from there. Is that all right?
I'm not happy about having theatres empty. Our theatres are extremely busy all of the time. Runs at about 95 to 98%, so we're very good at using our theatres. So it's going to be very difficult to catch operations back up. It is difficult. I'm the general manager of surgery. I want the surgical patients to be coming in. My priority is getting the right care for our surgical patients. Nobody wants to be in this situation where we're telling a patient that they're having their operation cancelled.
I'm having a blood test.
What's the blood test for?
I don't know.
To get ready for your operation, isn't
Get
it?
ready for the operation I'm having.
Do you know much about the operation you're having?
I'm gonna be a little slight taller. And yeah, it's going to be a big one.
You'll be as tall as Mummy, aren't you?
Well,
9-year-old Jason is at Queen's Medical Centre for a final examination before an operation to straighten his spine.
So it's a big operation. There's always risks with these things. Things like bleeding, up to life-threatening bleeding in this kind of surgery.
Jason was born with hypocephalus, which is extra water on the brain. He's gone through lots since he's been born. He's very brave. You can do that, Jason.
The advice from the NHS to cancel all non-urgent operations does not apply to paediatric surgery. But a shortage of specialist intensive care beds has meant Jason's operation has been cancelled twice before.
they're going to put me to sleep, put some rods into my spine to make it straighter. That is all I can say.
So just give a big cough for me.
He's gone through so much, but he's always smiling. He loves people. He gets people to love him, and it's just been such a joy.
Can you take some big deep breaths through your mouth for me?
He's been suffering, so it has made him very upset and uncomfortable. I'm just hoping it's not cancelled again.
So should we have a look and see where we can take some blood from? Just talk to me.
No.
Okay.
Come on.
No! No!
Teresa, gonna get your plasters.
Tell me what you're worried about.
I don't want it to hurt.
Have you had a bad time before?
Yeah.
Jason's procedure will be performed by Mike Grevitt, one of the UK's top spinal surgeons.
Jason, he's a treasure, isn't he? He's a treasure. This operation is about straightening his curved spine. Without it, there's a certain inevitable progression of the curvature which will affect his lung development. We're doing a system which will allow the rods to, as it were, expand with his growth in the same way like you would elongate a trombone. So this growing rod system, whereby the rods, as it were, glide along each other, guide his growth in a straighter manner.
Look at all that blood. Are you going to give me all that blood back?
I'm going to send it to the lab to be tested.
At first I was told September, October. Then I was given the 30th of November.
Sometimes in the winter when there's a lot of pressure with emergency patients and things, which is probably one of the reasons why you've had this shifting appointment, really.
Can understand, I can, but then seeing Jason suffer and go through things, it's hard as well, but I do understand.
Jason and his mum won't know if his operation will go ahead until the morning of surgery.
Ready to go, yeah?
Everything depends on the availability of a paediatric intensive care bed.
Right then, we've got quite a brief agenda for DLT today.
The surgical management team convenes to discuss the impact of the cancellations on their waiting list.
We have a responsibility as the Division of Surgery to turn our position around by whatever means that is.
Especially when the deficit's so big, actually that's the way of keeping some sanity and realism in the specialties.
We're always working within the same constraints, which is that we've got X number of theatre lists, that we've got this, that we've got... I don't feel like we've got any ability at the moment to push out beyond that.
Thank you very much, everyone.
Due to the unprecedented demand and the requirement from NHS England to reduce further, that's had a much bigger impact on our activity and our finances than we'd originally predicted. Part of the conversation is what ability do we have to try and get these cases back in and catch up.
That's actually really challenging for us in surgery because within the working week, we don't have any spare room to bring these cases back in. So we're still not going to be out of a winter crisis, and we're still, you know, we can still anticipate to have bed pressures during February.
Tourniquet up, thanks.
With the hospital full, orthopedic surgeon Tony Westbrook's work is restricted to day cases and patients who already occupy a bed.
I'm one of 18 elective consultants. So if I look at my operating schedule through to March, I would be expecting to do 60 elective cases in that time. So at the moment, the only patients that are showing are today's list. There's 5 on for a couple of weeks' time. I'll be surprised if they happen. So if I'm one of 18, you can work out sort of the mathematics in terms of what a massive effect that is.
One of the patients Tony can operate on is 75-year-old Peter.
It's all right, I'm proper Nottingham. So help me, look.
Peter has lung cancer and was admitted 3 weeks ago. The cancer has spread to his joints, leaving him unable to walk and in need of a hip replacement.
Hello, you all right?
My name's Asha. I've come to take you around to theatre.
The surgery is not considered urgent, but Tony can operate as Peter already has a hospital bed.
Any loose teeth, caps or crowns?
I only got one,
Just
too.
that one. Right then, we'll get going round.
I know enough about cancer not to really... I'm not saying to take any notice of. I do take notice of it, but it don't frighten me. They brought my wife, bless her, the love of my life. She came in here twice, breast cancer. And we got the all clear, which was lovely, thought it was great. But that come back. The oncologist turned around and says, I'm sorry to tell you, but you're dying. It just broke me up, it broke my heart, I'll tell you.
Have you got your gown tied up at the back?
Yeah.
Can I just undo it?
Come on, you can.
How we doing, boss?
All right, thank you. You all right?
Ready to go?
Are you Kevin?
Yeah, remember.
Professor
You don't
Kevin?
recognise me with my hat on.
All right, any questions?
No.
Shall we crack on?
Yeah, let's go on, crack
Okay,
on.
fantastic.
Peter was admitted because of his lung cancer. The cancer spread to different areas of his body. He was in absolute agony. So he was in a hospital bed. We've still got our theatre facilities and we've still got surgeon availability to do operations.
All right.
And therefore, because he's in a hospital bed, that's how we were able to do it.
So we're going to drift you off to sleep very slowly, okay?
Yeah.
You can see this is our tumour here. That's his hip joint.
He had quite marked hip pain, and the reason for that is his hip joint's been destroyed by tumour, so we want to try and give him quality of life. And for him, that is giving him the ability to walk, to go home, spend time with the family, and as much relief of pain as possible. Although he's very unwell from the diagnosis he's got, he comes across a lot more sprightly. And so if everyone thinks, OK, this is in his best interest to try and get him home, then you're reassured you're doing the right thing.
So the concerns we've mentioned is he's got metastatic lung cancer. As far as blood loss, we have blood available.
So that's the hip outer joint now. So what we've basically found is that the socket is just destroyed, but we've got a periphery of his own socket bone. So we've got to try and recreate that as his new socket, and then we're going to put a shell into this. So we're just working on that. Twelve restrictor on the board, thanks guys.
12 dog face.
Wait. Good.
Peter, hello. Hello, Peter, that's fantastic.
If we hadn't operated on Peter, he wouldn't walk on that hip. It would just be agony for him. The possibilities of him going home
would have to be a whole care package at home of someone who was in pain, not sleeping, not mobilising, and the quality of life for him is really poor. You know, my expectation with him, we're sort of giving 24 hours of downtime of just getting over the operation, but then I want to get him up and, you know, get him using a frame and crutches, and then just gently start introducing weight bearing through a hip. He's not weight bared for the last couple of weeks.
How are you doing? You're just coming round. OK, all went very well. You managed to do your hip for you. Fixed it.
You know, every patient's important, but, you know, he needs to be at home with his family.
The Trust has now cancelled over 200 operations, but the hospital remains full. Jo and her colleagues must now decide which operations to cancel next.
It's very difficult making the decision about which patients we can accommodate and which ones we can't. We can only do that based on the facts that we've got at the time, and you know we're having to deal with the immediate patient safety issues versus those who are coming in inevitably. If they're coming in for planned care, they're not as urgent as people that are necessarily coming in through the doors of ED that are needing a bed.
We can start, Jen, with just an assessment of where you think we will be by then.
OK, we're in a tricky place, certainly on this campus. We think with flu still escalating that we are still awaiting probably a second respiratory peak coming soonish. And we're starting this campus almost with no beds.
OK, hold on to the handles right down the bottom there.
One of the operations being considered for cancellation is Val's reconstructive jaw surgery.
Forward a wee bit.
OK, let's go through the plans for Wednesday then. So at the moment we have got 36 cancer patients, or those designated as clinically urgent, coming in. So those are protected.
We are relying on clinicians to be honest about what's routine and what's not, but I would really hope they're being honest about this. I've got 2 cancers, 2 clinically urgent and the 2 routines. Reconstruction of a mandible, so that's max fax. They'd say they're suitable for cancellation, so...
We'll have to cancel.
Yeah.
OK.
Yeah.
Thank you, everyone.
Have to cancel a patient. So, I've had an email from Jo telling me we have to cancel routines. The ENT is cancelled on the day, in fact, comment says prior to cancellation, 17 was routine. Valerie, the lady with the new jaw. So she's been cancelled. Brilliant. Hello, Jo, how are you? Yes. I'm on my way up to see Dilip now to talk to him about it, so yes. OK, all right. Cheers, Jo. Oh, sorry, I'm in the bowels of the hospital. Thanks, Jo. Bye. Have you got a Dilip in here? I've not got good news, Dilip.
Oh dear. No, I don't want to hear. I don't want to hear.
I'm not surprised. Valerie's cancelled for Wednesday.
You can't do that.
I've been told. What do you want to do? Do you want to talk to Jo?
Jo.
Thought. That's where it's come from.
What is the reason?
We've got no beds, Dilip.
Hi, Jo. How are you?
Hi, Dilip. I'm good, thank you.
Jo, I'm ringing you because I need a favour.
OK.
We have a patient by name Valerie.
You do indeed.
Who is a cancer patient. However, she is for reconstruction after cancer. Now, there's been a lot of work that has gone behind the scenes, and quite a few people are coming from Wolverhampton. Here, 2 of us have cancelled our activity.
Is that to assist with the surgery?
Yeah.
Right, OK. How many people are involved in her surgery, Dilip?
I mean, it'll be myself, another consultant from Wolverhampton, then 2 consultant anaesthetists.
So it's a 4-consultant operation?
Yeah.
OK. All right, then.
It's a lot of work that's going on.
OK. OK, well, in which case, she'll have to go ahead in that case.
Thank you very much. Shall I just pass the phone on to David for you to tell him so that...
So he gets the message from me.
1 second. Thank you, Jo.
OK. All right, OK, thanks, Joe. Hi. Yeah, on that basis, she needs to go ahead.
OK, right, thank you.
So the rationale for that is obviously because she's got 4 surgeons involved in her care, 2 of which are coming from outside the trust to support because it's major reconstructive plastic surgery post cancer operation. Clearly, that takes a huge amount of organising, so the ability to get that patient back in quickly is going to be really difficult, hence why we would choose to deal with her differently.
Doesn't sound urgent.
It is not at all urgent, but urgency, you're talking from whose perspective is it urgent? If you can't go out of your house, you can't eat, you can't talk, it is urgent.
You did say also that she was a cancer patient, Dilip.
I said, yes, she is a cancer patient, but she was treated for cancer. And it doesn't matter what it is. What she is now is the question. And what she is now is someone who is suffering. And if medicine is not about treating people who are suffering, then what is it about?
It's the morning of Val's surgery.
We just seem to go along well, don't we? Very dependable old stuff. Hello.
Just one for me.
It's been good to know. Considering we haven't been together all that long when I got the cancer diagnosis and I gave him his get out clause. He said, I'm not with you through the looks, so thank you very much.
What she's been through, she's still got a sense of humour to us, is amazing. I don't think many people will be like that after what she's been through.
Right, OK, I'll see you later then, Duck. I'll see you in a bit.
All right, ta-ta.
OK, fine. OK, right, everyone listening.
You've got down reconstructed a mandible using distraction.
Osteogenesis.
Thank you.
Operative duration? 3 hours, 2 hours, 4 hours.
After 6 months of planning, Dilip's 12-strong team is finally assembled for Val's groundbreaking jaw surgery.
Obviously, it's all new to us, I have to say, because I don't think even Dilip has done anything like this before. So if it works, you know, she's benefited a lot.
For my sins, I've known him for 20 years. You have to try your best to get your patients operated, which is not a nice position to be in, but it's a privilege to operate on patients. They are defenseless, and when they trust you so much, you will have to fight their corner, and that to me is the essence of surgery and medicine, and that's it.
It is quite amazing how it all fits using the models. Pre-operative planning makes all the difference. It does.
This frame gives us the final position and the shape of the jaw. So if we don't get this position right, then the final position and shape of the jaw is not going to be right. Yeah, that's fine. Good.
Okay. No, stop. You need to be further down. That's it. See, that looks good. Yeah, that's really good. You're nearly there. It's only a millimetre. That's it. Stop. Excellent. Top job.
So far, so good. Everything has gone to plan. Now we just have to wait and see how far it works. So the proof of the pudding is in 4 weeks' time. That's when we'll know.
Thank you, Val.
Hi, John. I'm Dilip Srinivasan calling from Nottingham. You recognize my voice. Well is done very well. Okay? Yeah, have a good evening. Bye.
So where are you going now?
White Hart. Go to the pub. Okay?
We've got sausage casserole,
No, thank you.
cottage pie,
No, thank you.
penny pasta in a tomato and basil sauce,
No, thank you.
chicken salad, or a sandwich. But we'll have to come back to the sandwiches if you want a sandwich.
Not much there. There's not much there.
Do you want us to come back?
Yeah.
Yeah?
Come back on that one. I like cooking. I'm a bit of a cook, though. That's why I'm picky.
Terminally ill Peter is recovering from his hip replacement operation. As soon as he can walk, he will be able to return home.
Yeah.
No, I sort them out, though.
Yeah, that's fine. You got your paracetamol there.
Yeah. Most of my life, I've spent working hard. I used to think, will I ever make 65? And I thought, no, not all the way I'm carrying on. But I made 75.
There you go.
Thank you, though.
All done.
Life's life, though, and we're getting old. And I am determined to get home. But I want to get home where I can live at home. I don't want people coming around looking after me, doing everything for me, all that sort of thing. When I get home, I want to get home and look after myself. It means a lot to a man like me. It means a lot just being yourself, going and talking to your friends and all this sort of business.
Morning. Good morning.
How are you today?
Oh, excited, nervous. It's going to be a long day.
You excited?
No, I'm pretty nervous.
It's the morning of Jason's spinal surgery. For the operation to go ahead, a bed must be available in pediatric intensive care.
The surgery might not happen.
Well, we don't know.
We don't know.
It's been cancelled so many times, so it's hoping. We've just got to wait and see, haven't we, when we get up there.
Yeah. It's got a mind of its own.
It has.
Maybe it could be a hotel trolley.
Do you know why you're here today?
Yeah.
What have you come here for?
Spinal operation.
A spinal operation. Are we going to make you nice and straight?
We don't know.
You don't know? Oh, okay.
It might not be happening, or it might will.
You're a bit nervous, aren't
Yeah.
you?
Yeah. And I'm not going any further than that.
You will. You're going to be a brave boy, aren't you? Just worried for Jason. Excited at the same time, really.
Well, I'm not. I'm nervous.
Oh, I know you are.
Kathy, it's Mike here. I'm up in PICU. We've got beds both for our case and also Masood's. Yeah. So no one else phones up PICU, okay? Give them a break, okay? Thank you. Bye. By any standards, it's an exceptional result. So yeah, that's one less thing to worry about.
Guess what?
What?
You're going to go to theatre this morning, and I even know what number theatre you're going to go into.
What number?
Number 16. And then when you wake up, you'll go upstairs to a special ward so they can keep an extra special eye on you for the first night.
Can Monkey stay now?
Monkey can stay with you
all the time, even in surgery?
all the time. And it shouldn't be too much longer now.
No, I don't want to go down.
Okay, listen, we're not going to go yet. And when we do go down, your mum will be there the whole time.
Even when surgery, can she stay the whole day?
Well, they'll be there when you go to sleep and when you wake up, okay?
He's a 9-year-old, sub 30 kilos, okay. He's got early onset idiopathic scoliosis.
He's small. We just need to keep careful watch on blood loss.
You come in here.
When will my operation be finished?
It'll be finished at tea time.
Right, and I'm going to be here waiting, okay?
It's a funny feeling going to sleep.
Your mummy's gorgeous boy, aren't you? Hey, your mummy's gorgeous boy.
Oh, that's it. He's asleep, Mum. We'll take good care of him. Thank you very much.
I love you.
This is the hardest bit of leaving him, okay?
Jason will be placed into traction to straighten his spine.
We have attached some pins to his legs, and also we're going to hold his head in a clamp, and between those two ends we can then apply some weights to essentially stretch the spine.
Metal rods will be attached to Jason's spine to fix it in its new position. Throughout the operation, Jason must be monitored continually for any indication that the surgery is damaging his spinal cord.
Just something like that, please. That's okay. That's pretty good.
People stare, and then one day he told some man, he said, don't just stare at me, he said, ask me. He said, I'll soon tell you, my spine goes like this. Things he comes out with, and you think, oh, you expect that from somebody a lot older. It's just a little superstar. Hello? Yeah, speaking.
It's quite technical surgery, but it went fine.
I was just saying I can't run, but I think I could run now.
It's just through these doors.
Mum, it went fine. It went fine.
Thank you.
It's all fine. It's okay. It's fine. It's fine. Yeah. This way, please, and...
Gorgeous boy. Hello, darling.
Look at Monkey, all dressed up. Hey, look. I know, darling. I know, you're a very brave boy. Oh.
Okay, so this is the X-ray. This is the original curvature, and there's the curvature now, and these 4 rods, 1, 2, 3, 4, and the idea is that as Jason grows, the rods grow with him. So we got there. Yeah, I'm sorry it took so long. Okay, have a good evening. All right.
Oh,
I'll leave you be.
now.
Jason, Monkey says hello.
Morning. Please enter the access code or meeting number, followed by the hash sign.
Right, Jen, do you want to start with a short assessment of where you think we'll be?
Today, both divisions are still reporting a minus bed stay, surgery and medicine going into the night. So no real improvement, I wouldn't say, on either site.
A month after the surgical cancellations began, the financial impact is becoming clear.
Rachel, just to say, I've got all the data back now for the return to NHSI.
Yeah.
So the loss of income has been estimated about 2.7 million.
Thank you, Paul.
Thanks.
Thanks.
Okay, bye. Bye.
Bye.
That's the sobering number. It is incredibly frustrating, and this is the first time we've cancelled electives on this scale, and it makes you think, where are we going next year on this?
You know, it's not just us, you know, experiencing this problem. This is happening everywhere. So in these jobs, you want to be able to fix it.
Hello, my darling. What you got me?
Peter is still unable to walk. For now, he must remain in hospital.
Any good boys?
Yeah.
What have you done today?
I got a lollipop.
And what else? What did you do today?
I can't remember.
He's definitely a character, you know what I mean? He's on some level. And he makes me laugh, you know, he's a funny character. Talks about his dinner for about half an hour. I bought some beans the other day down there, gorgeous beans. You know, like that sort of thing, sort of going about his chips for half an hour. But I love him for it, do you know what I mean? I couldn't want him any other way. But yeah, he's a character, he's a dude. He'll talk to absolutely anybody. You catch your eye, then he'll tell you his whole life story. My dad worked on Queen's Medical Centre, and he did all the steel erecting for the place and everything. And when I was little, I used to go and see him when there was a foreman on there. And I remember when the Queen came and opened Queen's Med, and I was in there, it was in the A&E, and these are two lads sat on these seats. And he tells everybody what he does. And obviously we got him in the wheelchair, and as I was wheeling him off, he went, hey, I built this place. As I was pulling it, I was like, Dad, they don't want to know this shit. They don't want to know, you know what I mean? Getting out, getting your hip sorted out, bish, bash, bosh, off you go.
Once I can walk and get back upstairs, I'm out of here.
It's hard to talk about, really. I'm sure there are people in worse situations. I mean, look at him, he's all right, but, you know, he has got terminal cancer. But we don't know how long, you know, he's going to live for. I mean, he's going to live for, obviously, you know, I don't know. It's a difficult one, isn't it? Because these sort of things, you don't know how long these go on for, I suppose. Do you know what I mean? It could be 4 months, could be years, could be 2 years and stuff. But with his optimism, you know, it may most probably help. You know, it's like nothing. It almost acts like there's nothing wrong with him. Just try and get him home and you know, get him back on his feet again and everything else like that. So that's that. I just take every day, you know, day by day, and then whatever comes after that comes after that.
The frame to grow Val's jaw has been in place for a week. Today, X-rays will reveal if the procedure is working.
How's everyone feeling?
We're more nervous than she is, I think. Val's always been happy-go-lucky, though. She says whatever will be, will be. But we obviously want it to be. So, keeping everything crossed.
Is this today's? Yes. Yes. Hey. Fantastic. That's lovely. It's moving, which is exactly what we want.
That's good.
Are you happy?
Great.
If Jason is happy, I'm happy.
It's very good.
Fantastic. Shall we bring her in? Hello. How are you? It is moving. Okay? On the X-ray, it moved really well. Yeah? It's done fantastically. You see, this is the gap, the day immediately after the surgery. Today, this is the gap.
As long as it's moving and the process is working, it'll be fantastic, won't it? Beginning of a new era for Val.
already. Hold on a minute. Is there a way we can do his height, please?
Jason has spent the last week recovering in hospital.
44 and a half?
Right,
Don't know what that is anyway, we'll put it on. 144 and a half. He's 4'8".
Wow. 4'8"?
Yeah.
I'm 4'8".
If he can master the stairs, he'll be able to go home.
You can. Right, you just focus on your walking and doing the stairs then.
Okay.
Okay?
What if I fail?
You won't. Can we say it with us? Good lad. And you're going to turn it around. Good lad. Use that one again. One step at a time.
Okay.
Okay? Good lad. Well done.
Let's wait.
Well done. You've passed.
I passed.
Well done.
I passed.
You don't have to keep staying in here now. You can go home.
Oh, Jason, I'm going to miss you. Take care, Mum. Take care.
Yeah.
Hello, how are you? Yeah, take care, Jason.
I used to love fishing, being in the fresh air, all this business. I don't do that now. My caravan down at Jingle Bells, Ingle Bells, but we call it Jingle Bells. I used to enjoy that. Lovely.
You told me about your grandkids, Peter.
Oh, I love them. They was here last night, and see his little face, our Bertie always laughing. Our Alfie's got that little bit in his face where it goes. And they were asking me about dying. And I was trying to explain to him what happens when you die. And he says, are you going to die, Grandad? I says, I hope not before you've grown up. He says, Grandad. I said, what, darling? He says, I don't want you to die. Things like that get here. My grandson don't want me to die. There you go. So, like I say, these things happen. That's how it is, isn't it? So I says to him, well, I'll try not to, Alfie. I'll try not to die.
The NHS recommendation to cancel all non-urgent surgery was due to end on the 31st of January. It's now March. The hospital is still full. The Trust continues to cancel operations, and surgical waiting lists are growing by the day.
We've got some major backlog issues now, particularly in spines and elective orthopedics, that are going to take serious months of additional work to get the backlogs back down. Elective orthopedics had 90 patients at the end of December waiting over 18 weeks for their operations. They've now got 205 because of all the cancellations that they've had during January. To clear 205 patients, or to get it back down to sort of the level that it was at before, is massively challenging.
X-ray, thank you. Last year we were operating within probably an 8 to 10 week window from seeing patients in outpatients. Unfortunately, we've gone from sort of 8 weeks to getting close towards 8 months, and that's a massive change. So if it's impacting on your life or your work and you want your operation done, in a short period of time, that's something that unfortunately at the moment I can't offer.
In an ideal world, we would want all the activity and the income to be done within the Trust. But we don't have enough capacity from a theatre's point of view to necessarily do that. So we need to look at alternative options, maybe slightly more unpalatable options around sort of maybe sending stuff out to the private sector so that we can clear some of the backlog.
The Trust must now decide whether to use private hospitals to clear the growing waiting lists.
We have increased the number of patients that have got extended waits. We now have 508 patients waiting over 26 weeks, and we have 68 patients waiting over 40 weeks. And our agreement with the commissioners is that actually we should have no patients waiting over 40 weeks. You know, we have options internally, but the thing that we've got to be mindful of is that most of this has an impact on our beds, so potentially just puts pressure back into the system. So, you know, our other alternative is obviously use of external resources. And it's always been a difficult and contentious sort of conversation, but, you know, that is where we're looking at use of the private sector. There is a risk to us putting work out to the private sector, and it's not what we would choose to do. I think we have to look at it as, you know, we're renting space, so this is about using capacity.
The use of the private sector is generally contentious. But we do need to be mindful that these people are our competitors.
The priority for me are the very long waits on quality grounds, and that's probably where the private sector discussion is most pertinent, because for some of these specialties, that's the only safety valve we've potentially got.
So I think we're clearly getting into quality of care issues for some of these patients with these long waits, aren't we? And for me, this seems a very proportionate response to trying to deal with that.
I don't like the idea of going out to the private sector, but as Joe says, it's effectively increasing our capacity by using theatres and beds and nursing staff outside of the trust. We've got commitment from our surgeons to actually do that as part of their NUH activity, so we wouldn't have to pay them separately. So I do support these recommendations.
So have we got approval to get on with that?
The answer to that is yes. I think thank you, Joe and Rachel.
Thank you.
Who's winning from these decisions you're making, do you think?
Nobody's winning. There isn't a winner in any of this.
Apart from maybe the private sector providers?
Yes, potentially there could be some win in it for them, I suppose.